A great pleasure to introduce my good friend Bruno Migliara. And so we stay in the same area, pushing the boundaries in very complex BTK. So I assume, Bruno, is not going to be lesions of 2 and 3 centimeter, but very complex below the knee disease. Please.
Okay, thank you. Good evening to everyone. And first of all, of course, thank you to Biotronic for supporting this talk. Now we are shifting a bit to a more practical section. About the Oscar device. So, of course, we know that in every hour endovascular treatment, the first thing is to cross and then to prepare and to treat the lesion. Now, with the Oscar device, we have a device that is able to combine all this action, and because in Oscar device we have a super catheter and combine with the dilator with a specific tips that allows us to cross also the really complex CTOs. On the other hand, we can remove the dilator and we can put into the super catheter the balloon, and we can use this in different lengths. So the Oscar device exists in 2 different sizes, the 4 and the 6 French. 3 elements. The super catheter. The super catheter is the working channel. In the super catheter, we can put the dilator or the balloon. This super catheter has a reinforced tip, this to reduce the risk of deformation. The second element is the dilator. This is the specific tip of the dilator is an olive steel tip, and this allows us to reduce the deformation of the tip, to cross long occlusion, also a really calcified occlusion. It's really important to understand that when the tip is close to the super catheter, we have more pushability, but it's also possible to extend the dilator outside the catheter, and so to increase the trackability of our device. In this video, we can see this concept. So more pushability when the tip is close to the super catheter, and then when we have to navigate our occlusion, we can push the dilator outside and improve the trackability of our system. The third element is the balloon. This is a really particular thing because we can use this balloon in different lengths, from 2 to 18 centimeters, and so we have the possibility to customize our PTA based on the lesion length. This to reduce the wall stress of the artery, the overinflation of the artery, and then to reduce the dissection. As you can see in this video, it's possible to dilate all the lesion. If there are some parts with higher resistance, we can focalize the dilatation in this area, and so avoiding an overinflation of the other area of this artery. And then we work with high pressure in a short length. So, after this short introduction about the features of the Oscar, I think we have to shift to the clinical cases. Of course, when we treat this artery, BTK and BTA artery, the lesion in this area are in some cases more complex than in the proximality, small vessel, long occlusion, calcified, different wound, pure outflow. And usually we use in this area, we decide to choose the 4 French, so the smallest one Oscar device. This works on a 1/4 guide wire in a 4 French sheath. The balloon ranges between 2 and 3.5 millimeter in size, and from 2 and 18 centimeter in length. So this is the first case, a quite complex situation in BTK. So So the only patent artery is the peroneal, but the angio of the foot show in lateral and AP projection that the flow, the peroneal is not very good to supply the flow in this foot. The flow is really, really poor. So in this case, we have to try to open at least one tibial artery. In this case, we decided to try to reopen the anterior tibial artery and to increase the flow into the foot. We engage with the Bernstein catheter the anterior tibial, and then we remove the Bernstein. We try with the dilator to go into the anterior, but was not able. So in this case, we remove the dilator, we place the balloon, short balloon, just to do a predilatation of the origin of the anterior tibial artery, and then we push the system, the support catheter, on a partially inflated balloon. After that, of course, we remove the balloon and we go on with the dilator, combining the maximum pushability with the trackability, with the extension of the dilator. I think one of the most important advantages when we are working into the anterior tibial artery is to avoid the prolapse of the guide wire of the support catheter into the tibioperoneal trunk. And with the Oscar device, this is possible. And then this increases the pushability of our system. When the system stopped due to the calcification, we remove the dilator, we place the balloon, we do an initial inflation just to try to go on. As you can see here, with the combination of the guide wire and the dilator, it's possible to arrive till the ankle level. We inject the contrast. We try again in this heavy calcified artery to go on, but unfortunately at the ankle level, the guide wire goes outside. So now we have to shift. We do a retrograde puncture of the, in lateral view, of the dorsalis pedis, and then placing a V18 guide wire and a 6i support catheter. In this case, we are able to cross in retrograde this heavy calcified occlusion, and finally we regain the guide wire through the proximal, through the Oscar to the proximal sheath. We change from distal to proximal, and so we do a predilatation of this vessel, and finally we do the final dilatation. And this is the final result with a really good flow through this anterior tibial artery, faster than into the peroneal, a flow through the tarsal system, but in AP projection we can see the flow in the direction of the force 2, that is the location of the lesion. The second case is another case with a necrosis of the force 2. In this case, the angio is quite good with a good posterior, good lateral plantar, but probably this is not enough to obtain the flow in the direction of the force 2. So we decided to try to reopen the anterior, and again, Bernstein catheter, 1/4 guide wire, we engage the anterior tibial artery, and after that we remove the Bernstein catheter and we place the Oscar 4 French. We push the Oscar with the tip of the dilator close to the support catheter, and finally we push a little bit, we extend a little bit the dilator, and so it's possible in this case to have a super selective angio of this artery to see better the situation. And so we decided to go on with our guide wire and with the dilator. We navigate intraluminally this part of the anterior tibial, and then we extend the dilator to improve the trackability of our system till we are able to arrive again at the ankle level. In this case, we shift from intraluminal to subintimal. In this long lesion, sometimes we have to shift from intraluminal to subintimal to obtain the crossing. And finally, with the dilator, we are able to cross the occlusion at the ankle level and to place the guide wire in a distal patent lumen. In this case, we can see the guide wire goes into the tarsal artery. So we change the image, the projection in AP. We try to navigate this tarsal in order to try to arrive in the direction of the first two. After that, of course, we do a dilatation. This is a 2.0 millimeter balloon just to prepare the artery. In the next slide, I want to show how is able the dilator of this device to navigate also a really small artery like this tarsal artery, and then to support our guide wire, and finally to go around this. This is not a pedal plantar loop, but it's a tarsal loop, so a really small loop. And finally, with the support of the dilator, the guide wire is able to regain the patent lumen into the dorsalis, into the lateral plantar. And so at the end, of course, we do a post-dilatation, but the most important thing is the final result. With this improvement of the flow into the foot, in AP projection, it's possible to see that through this improvement of the flow through the tarsal artery, we obtain this blushing into the first two, and this is the final result. So just to conclude, it's a really all-in-one device, the Oscar device, because it allows us, above all in complex situations, to cross better the lesion and also to prepare and to treat the lesion. Thank you a lot for your time.